Hello and welcome to Expert Perspectives from the 2014 Great Debates and Updates in Hematologic Malignancies here once again in New York City. So these are capsule summaries of the most important data and the important take-home messages from this annual Great Debates meeting. We felt that this would be of real value not only to those of you who weren't able to make the meeting this year, but also for those who were able to be here, but still will have their learning reinforced with these brief interviews. So joining me for this first Expert Perspectives from this year's meeting is Dr. Robert Orlowski, Chair of the Myeloma Section at MD Anderson Cancer Center. So Bob, thanks very much for joining me. I know that you're anxious to get home, but I appreciate your taking extra time to spend a few minutes with us.
Well, thanks for having me, and I think this will be a valuable set for your constituents and hopefully for the doctors and patients as well.
Right, and so we just finished the morning session, which is all plasma cell disorders and multiple myeloma. There were a number of interesting debates and a few interesting lectures as well, and we'll see if we have time to go into some of those. But I want to start off with early plasma cell dyscrasias with smoldering multiple myeloma. There's been a lot of interest in recent years in identifying groups of smoldering multiple myeloma patients who are at the greatest risk. We know their risk is higher than just the standard MGUS patient, but can we identify the patients who are at the highest risk? Does their cytogenetics matter? And is there value in preemptively treating those patients as opposed to waiting until they develop CRAB criteria?
Well, those are great questions and the topics of many ongoing studies. But there are a couple of ways that we can identify those who are at especially high risk. One way is by using the Mayo criteria, which look at patients who have at least 10% bone marrow involvement and a monoclonal protein of 3 grams or more, and people who have both are at especially high risk of progression, especially in the first 5 years, compared to people who have only one of those two criteria or none of those two criteria. A second set is from the Spanish group, and what they looked at is whether the plasma cells that were present in the bone marrow had an abnormal immunophenotype, which you can detect by flow. And this is now a standard test that's available for everybody, both in the academic setting and in the community, as well as whether there was immunoparesis, which means a decline in the uninvolved immunoglobulins. So for example, if you have IgG myeloma, immunoparesis would mean a lower than normal IgM and or IgA. And also in their system, if you had both of those factors, more than 95% abnormal immunophenotype of the plasma cells in the marrow and immunoparesis, your risk of progression, again, especially during the first 5 years, was much higher than if you only had one of those or if you had neither one of those. Which of the two systems is the best, I think we still need to understand better. You also asked about cytogenetics, which is a great question because there were a couple of studies, including one recently from SWOG, that showed that patients who are in the smoldering phase but have high-risk abnormalities, for example, deletion 17p, are going to probably progress to symptomatic disease more quickly than people who don't have high-risk abnormalities.
Well, and that's such a high-risk disease, even in active multiple myeloma, then getting a jump on their therapy would make some sense.
Totally. Other categories that you might want to think about treating early: for patients that have at least 60% involvement of the bone marrow with plasma cells. There's a small study from the Mayo that says that their time to progression is less than a year, in which case maybe watch and wait is not appropriate. And if you have an abnormal free light chain ratio, especially above 100, that suggests also a high risk that perhaps waiting where patients can develop renal insufficiency or bone disease is not appropriate. The bone disease is an important point, though, because a lot of this debate has been brought to light again because of the Spanish study where they did lenalidomide and dexamethasone versus observation for high-risk smoldering patients. And it was published in the New England Journal, and what they showed is a better progression-free and overall survival for starting therapy earlier. The problem is that they did not look for bone disease with MRI or PET scanning, and many of those patients, therefore, may have already had symptomatic disease at the time that they went on. So in addition to looking for these high-risk features, it's important to look for bone disease with either a PET or an MRI, and in some cases you may need to do both depending on the patient. And there are a number of studies now that show that if you have several PET-positive lesions with an SUV of at least 4, those are people you should probably treat. Same thing with an MRI. If you have bone disease, now this is not the same as marrow abnormal signal, because that's to be expected in myeloma. But if you have bone lesions on MRI, exactly, if you have cortical destruction, that's symptomatic myeloma. That should be treated like regular symptomatic myeloma with bone lesions on a bone survey.
So if you have a patient who meets the criteria for smoldering multiple myeloma, and you think they could be at high risk, but you don't have any evidence on bone survey of bone destruction, those are the people who should get MRI and PET?
Yes,
or
very
should you
much.
do everybody with smoldering myeloma?
For patients who have low risk in terms of smoldering, low-level monoclonal protein, low-level bone marrow involvement, no immunoparesis, and not more than 95% involvement of abnormal immunophenotypic plasma cells, their chances of having symptomatic disease are much lower. So if they're totally asymptomatic, I would be tempted not to put them through that additional testing, but also have a very low threshold for obtaining it if they have any back pain or neurological symptoms that make you concerned.
Very good. Well, let's move on to frontline therapy. There was a lively debate of the RVD regimen, or VRD, however you want to sequence those initials, versus the novel triplet of carfilzomib, lenalidomide, and dexamethasone, or CRD. And there is an ongoing phase 3 trial, but carfilzomib has been on the market for some time, and I'm sure since it's a highly effective proteasome inhibitor, some people are going to be tempted to use it up front. So this was frontline therapy for transplant eligible patients. So give us a synopsis of what you feel about this. You were one of the debaters in this debate, and you mentioned that it was a CRD by a nose with the two horses lined up. But talk about efficacy and durability of responses that we're aware of, the cost, which is always a factor these days, especially with the possibility of bortezomib becoming generic in the near future, and in the convenience of once a week or maybe initially twice a week, but eventually once a week bortezomib versus 2 days in a row of carfilzomib.
Well, you've touched on all of the important points which were brought up in the debate. We should probably preface the summary by saying that, of course, neither RVD/VRD nor CRD yet have Category 1 recommendations, for example, from the NCCN, because we don't have phase 3 trial data yet. And for right now, carfilzomib is still only approved in the relapsed and refractory setting after 2 prior therapies. That having been said, comparing the phase 2 studies, different trials, not randomized, that we have, it seems to be fair to say that the VRD and CRD regimens have comparable overall response rates. Both of them run almost 100%, 95 to 100%. If you look at the response quality, for example, very good partial remission, or the proportion of patients in stringent or near complete response, as well as complete response, those also seem to be comparable. One difference is that in the available data, it seems that the progression-free survival for CRD may be longer, which may mean that the durability of the benefit is improved. If we look at things like toxicity, again, comparing different studies, we know that carfilzomib in general has less neuropathy than does bortezomib. But a lot of the data early on with VRD were with bortezomib given intravenously twice weekly, and we now know that if you give it subcutaneously, or if you give it once weekly or both, that the rate of neuropathy will be lower, could be comparable to that with carfilzomib. Other side effects, I would say, were fairly similar, although with CRD there was a little bit more hyperglycemia. With both of them, you have to do prophylaxis against both thromboembolic events because of the LEN and the DEX, and with both of them, you have to give zoster prophylaxis as well.
Right.
From a convenience perspective, when you can give bortezomib as a subcutaneous injection and possibly once weekly, there's going to be increased convenience compared to what you could do with carfilzomib, which is still only available as an IV that you do 2 days in a row for 3 weeks on and 1 week off. And probably from a cost perspective, even with trade versions of bortezomib, I would think that the cost of CRD is going to be higher because, first of all, each cycle has more lenalidomide, and also you incur greater infusion costs with the carfilzomib with 6 infusions per cycle versus only 4 if you go with the traditional VRD. So I think the answer hasn't yet been shown. As you pointed out, there is an ongoing, just started, so unfortunately we won't have the data for a few years, but there is an ongoing study comparing VRD and CRD head-to-head. And right now, I think either one of those would be an excellent option. Although, as you pointed out, I sort of thought that perhaps CRD was a winner by a nose because the durability of the response was slightly higher. And we don't just want a high overall response rate, but we want that to hold as long as possible as well.
So the argument was also made that perhaps you should use bortezomib first, since there is fairly good data for carfilzomib in relapse refractory. But then we also know that we have a couple oral proteasome inhibitors sitting in the so waiting to come online, and they will be ready within the next few years, I would think, especially the MLN, the Millennium drug, the ixazomib. So is that a reason that one would tend to go with bortezomib first, or is that not likely to be that important?
I think we still don't have a lot of data in that space, although we had an abstract at ASH last year from MD Anderson looking at this question, and we found that even patients who progressed on carfilzomib could still have a good response with a subsequent bortezomib-based therapy. It was too small an experience, I think, to make a firm conclusion. And as you're pointing out, we've got ixazomib and also aprozomib, which are 2 oral proteasome inhibitors that are coming, and they may be active, especially in combination with other drugs. For example, if you progress on CRD or VRD, you may be able to go back in with a proteasome inhibitor plus cyclophosphamide or plus pomalidomide. There are already data about that. So those may be options for the future, and I don't think right now we have enough data to say that just based on that one would prefer VRD as opposed to CRD.
Very good. All right, well, let's jump over to the transplant ineligible group. And this group seems to be shrinking as the eligibility for transplant the age keeps rising into the mid-70s. It seems like. So for years it was melphalan-prednisone, and then bortezomib came along. We had the VMP regimen and then the MPR regimen. What is the role for melphalan? Pretty marrow-toxic drug. Is this something we should be using in older people whose marrow's may not be quite as vigorous as they were when they were in their 30s, 40s, and 50s?
Yeah, great question. In terms of melphalan, we should point out that we had a panel discussion, and one of the few things that everybody agreed on is that there is still a role for stem cell transplant, even in the novel agent era. So at least for now, none of us feel that melphalan in the transplant eligible population is in danger. But you're bringing up a great question about folks in the patient setting who are not eligible for transplant. Melphalan-based therapies in America have never been very popular to begin with in those patients, considering the risk for second primary malignancies, which we're seeing in that patient population. I would say that for the vast majority of people, melphalan should not be considered as part of frontline therapy. And we have now real data to back that up from the so-called FIRST trial, which was presented at last year's ASH plenary session, where one of the arms was MPT for 72 weeks versus Lendex for 72 weeks, or Lendex continued until progression. And we know from that, one of the largest studies in myeloma ever done, that the Lendex until progression beat out the MPT arm and had fewer second malignancies because there wasn't melphalan involved. And in general, usually 2 drugs are going to be better tolerated in this older, slightly more fragile patient population than 3 drugs. I would only in a very, very rare patient think about melphalan as a drug to consider. One option, though, also is bortezomib and dexamethasone.
Absolutely.
Although we have VMP data showing it's better than MP, there also was a randomized study comparing VMP with VD and VTP, and that showed that just bortezomib and dexamethasone had the same progression-free and overall survival as the triplets with, in general, better tolerability. So I would say that for the vast majority of these patients right now, a doublet such as either RD or VD would be the best way to go.
So should we follow the Mayo M-SMART criteria as far as standard risk, somewhat higher risk, and really high risk, like the Del 17Ps, in choosing whether or not to use a doublet or a triplet? And although we don't like VMP much anymore, a somewhat similar regimen would be Cybor-D, a different alkylating agent better tolerated with VD. So they could almost call it CVD. But is that a good algorithm to use with the different standard and higher risk categories?
Well, definitely anybody who has higher risk, certainly by cytogenetics, but also in some regards by things like an elevated beta-2 microglobulin, even in the novel agent era. ISS stage 3, which is mostly driven by a high beta-2, is a poor prognostic finding. I would say anybody with that high-risk phenotype should be somebody who should receive bortezomib, including therapy. And if they're robust enough in this older patient population, I would be very comfortable going in with a triplet, either VRD, as in the transplant-eligible patients, or Cybor-D, as you've mentioned. I think for the standard risk patients, I would still consider either RD or VD. I like VD in particular because it seems like there is a very rapid cytoreduction of myeloma. So for patients, for example, with developing renal insufficiency, where you can give full dose bortezomib without having to adjust it and worrying about increased toxicity, I would still think about using that in that setting. But we really need some randomized studies to look at the standard risk patients to see whether RD or VD is better. And as you pointed out earlier, with the oral proteasome inhibitors coming, I think those will be a big upgrade, because we're going to soon be able to do doublets and triplets. as all oral outpatient therapy, which will really be a great thing for these people who want to spend as much time as they can with their family and not schlep back and forth to the office.
Very good. Well, let's finish up with a brief look at the double refractory, the patients who are, undoubtedly getting exposed to bortezomib and lenalidomide, and then their disease progresses. There are a lot of options available. We've already talked about carfilzomib and a little bit about pomalidomide, but there are a number of novel agents in the pipelines, whether it be monoclonal antibodies or HDAC inhibitors or the oral proteasome inhibitors. How do you categorize patients, and how do you segregate them into various treatment options when they've already been exposed to and relapsed after len and bortezomib?
Yeah, great question. You've mentioned the two drugs that are already approved in this space, which are carfilzomib and pomalidomide, either alone or with low-dose dex. Both of those can be given for people with at least 2 prior lines who had both bortez and len and were refractory to their most recent therapies. And a couple of nice studies have shown that if you combine the carfilzomib with pom and dex, and also bortezomib with pom and dex, you can get response rates around 80% in this difficult to treat patient population. So anytime it's possible from a patient perspective, meaning somebody is robust, I would go with that kind of a triplet combination.
Or a carp-MD,
Exactly.
or carp-MD.
Other approaches that look very promising, there's a kinesin spindle protein inhibitor called filanosib, which has shown up to a 30% response rate in triple refractory patients, especially if they had low levels of a serum marker called AAG.
Right.
And that's going to be available right now, soon we hope, in a clinical trial that, if positive, would lead to drug registration. We're screening patients now for that study. Monoclonal antibodies, which you mentioned, very exciting because it's a new mechanism of action. The main ones that have had a lot of success so far, elotuzumab, which is anti-CS1, and also daratumumab, which is anti-CD38. There's also SAR 650984, which hopefully will have an easier to say name at some point, but is another anti-CD38. The response rates there have been very good, both alone and in combination with len and dex, although since it's still early, we don't know about double refractory patients there. But we're certainly hopeful that these monoclonal antibodies will be effective. And then a new drug which we're hoping to have available later this year is panobinostat, which is a deacetylase inhibitor. And there is going to be a presentation at ASCO of a randomized study comparing bortezomib and dex plus minus panobinostat for relapsed patients. But we already have published data showing that you can use that 3-drug combo in patients with bortezomib refractory disease and get very good outcomes. So the good news is that we're going to have a lot more options. We still, though, do need to get as many patients as we can onto clinical trials because we've got really the most exciting drugs yet to come. And to make them available, we've got to put patients on the studies to show that they're as exciting as we think they are.
Very good. Well, Bob, thank you so much. Really appreciate your taking time with us. We'll let you scoot off to the airport, but thanks again for being with us. And thanks to all of you for watching this segment of Expert Perspectives from Great Debates and Updates in Hematology 2014. We will be back later this weekend with Dr. David Steensma to talk about myeloid disorders, and Dr. John Leonard, who will review the lymphoma data presented at this year's meeting. Thanks again.